Hello, and thank you for joining the Pituitary Network Association's webinar program, which is brought to you through the support of our sponsors and our expert contributors. The PNA is dedicated to educating people with pituitary disorders, their families, and their healthcare providers. The PNA is a nonprofit organization that relies on the support from our members and our donors. During the webinar, feel free to type in your questions at any time, but please note that we will hold them till the end of the webinar, and we have allotted as much time as possible to answer as many questions as we can. Today's webinar, Parallels and Pitfalls of Using Guidelines in Management of Acromegaly, is being presented by Dr. S Blevins. Dr. Blevins is the director of the California Center for Pituitary Disorders at the University of California, San Francisco. He is a professor of medicine and neurological surgery. He trained at the Johns Hopkins Hospital in Baltimore, Maryland, and held previous faculty positions at Emory University School of Medicine in Atlanta, Georgia, and Vanderbilt University School of Medicine in Nashville, Tennessee. Dr. Blevins' main clinical interests are in the evaluation and management of patients with various disorders of the pituitary gland and hypothalamus. He has extensive experience in treating patients with acromegaly, Cushing's disease, prolactinoma, and other pituitary tumors, diabetes insipidus, and hypopituitarism. He also has extensive experience in the management of patients with growth hormone deficiency. He has edited several textbooks on pituitary tumors, including a book on Cushing syndrome and another on medical decision-making and neuroendocrinology. His current research interests include outcomes measures in patients with various pituitary disorders. When not engaged in the practice of medicine and other scholarly activities, he spends his time sailing, painting landscapes and portraits, and oil, and playing and performing music on the bagpipes of Great Britain, Scotland, and Ireland. Dr. Blevins, thank you so much for taking the time to join us today and for your involvement in our webinar program. There's going to be a brief delay as we change presenters. You should see on your end to accept. Great, I see your screen.
All right, good afternoon. Can you hear me?
I can hear you perfectly. It's all yours.
I said good afternoon. It's actually morning where I am, so.
Us too.
I'm sure it's afternoon somewhere, maybe even
Absolutely.
evening or the middle of the night. So. Thanks for the opportunity, and it's great to join you folks. The first thing I'll come in is the title, Parallels and Pitfalls of Using Guidelines in the Management of Acromegaly. I was actually dictating the title when I was responding to the email with regards to the title of the presentation, and it was supposed to be Perils, but the transcription thing that we use at work came out as Parallels, and I got to thinking, well, they kind of messed up the title with the dictation thing. I messed it up, but let's think about this with Parallels, because I think that word's appropriate as well. Based on the title, Perils and Pitfalls, you can sort of get the idea up front that I'm biased against the use of guidelines in the management of acromegaly or for any disease process for that matter. But when the word parallels came up, I got to thinking, and it's, well, maybe the guidelines parallel what an expert physician would do, and perhaps they are useful to physicians who are uninitiated in pituitary disorders. Say you've got an endocrinologist in a small town who sees mostly diabetes patients and has an acromegalic patient come to see him or her for evaluation, and maybe they need to be in parallel with what we're doing at tertiary medical centers. So parallels is perhaps a good word, but really the focus of this talk is on the perils and pitfalls of using guidelines, because I think that there are traps for the unwary, and patients sometimes get caught in the middle of what experts think and what the guidelines say and what the insurance companies want to do and how the insurance companies follow the guidelines and so on. So we'll talk about some of that now, and hopefully the information that I will discuss will empower you, the patient, to sort of proceed forward with your physicians using guidelines in a reasonable way, but more importantly, individualizing care. Because you can give me 100 patients with acromegaly, same size tumor, same level of IGF-I, and you have 100 different diseases because you have individual responsiveness to the IGF-I levels and different tissue sensitivities. And everybody's different, has different coping mechanisms and support systems and different jobs. So you get 100 different illnesses, even though the tumor and the IGF-I level could be the same. So anyway, let's proceed with the first slide. This is the many faces of acromegaly. Here on the upper left is Jorge Fascinetti, who's my patient and partner at Pituitary World News. On the lower is a patient of ours that had a very large goiter who came out of the Sierra Nevada mountains for heart failure, and we found that she had heart failure and a goiter and spinal stenosis due to uncontrolled acromegaly. The Irish giant is in the center, showing him up against the size of a normal person. This individual has been studied, and we know he had the AIP gene mutation. It's very common in the UK. The center lower is a movie star. I don't remember his name at the moment, but he was a gentleman who was cast in movies as a monster because of his features. And then Mary Ann Bevan, who was described as the world's ugliest woman, who toured in a circus because of her acromegaly and her appearances. So acromegaly has different faces. Every single one of these people has a different situation and a different lifestyle and consequence and outcome of the illness. And I show this because I want to sort of start out by illustrating, when I give a related talk to this to physicians, I try to make the point that every patient is different, and to use guidelines which sort of are good for a population isn't necessarily the way we want to treat our individual patients. And I do think, as I said, patients deserve individualized care, and that care individualized according to their needs, but also based on evidence in the literature about, you know, sort of how effective drugs are, surgical procedures, whatsoever, but also the art of medicine. I think the art of medicine comes from physicians who take care of a lot of patients with particular disease process and can sort of redirect therapies or the patient or other healthcare providers or insurance companies to certain therapies based on the art and the science of medicine, but really based on experience. Patients deserve the most appropriate drug for their situation. One drug may work better for one of you, another drug may work better for another. Also, you deserve to participate in decisions regarding your care, and rather than having a physician say, this is what we're going to do, because the guidelines show it, you should be able to decide based on the side effect profile, the way you have to take a drug or undergo a procedure, as to which is the route or the path that you want to take. You're the one with the disease process, and you should be the horse driving the cart, so to speak. The doctor shouldn't be the horse driving the cart. The doctor's there to help you make informed decisions, so you need to participate in your health care. You also deserve a swift resolution of your disease process, and I'll talk about an example of what I mean by that later, so that you know, guidelines should not result in a delay in appropriate therapy as they can. And I do believe, even though it's not related to guidelines, is that you deserve the very best healthcare team and center available. Technology has shrank the size of the world. We have the webinar now that we wouldn't have had when I was training. People can now get information online, and you can get on an airplane and travel. And air travel doesn't really cost much more today than it did 20 years ago, for example. So you can travel to get good health care if necessary. So these are all the things that patients deserve. I think there's some more. Well, there's some more later, I think. When it comes to guidelines, the first thing I'll say is that there are about 3 different groups, probably 4, that now put out these guidelines for the management of acromegaly. And they're a group of often self-appointed experts who get together, and I don't participate in these things because I'm opposed to guidelines and what they do to the practice of medicine, but they're self-appointed experts who get together and disagree over most things, but ultimately come up with a list of recommendations or things that they want to say to sort of guide treatment. And interestingly, it hasn't worked with just the American Association of Clinical Endocrinologists doing guidelines. The Endocrine Society has to get in on it too, and so does an Acromegaly consensus group, and then there's the European people. You'd think if there really was a consensus and a useful set of guidelines that we would have one set, but we've got 3 or 4 sets. And they change every 2 years or so. They are biased by those who write and sponsor them, and who pays for them, and what drug trials they contribute to, etc. They're often based on trial information. So this study showed that, or this study showed this, and that doesn't often apply to the clinical practice of medicine. We'll talk about some examples of how that trial information is different than the real practice of medicine. They don't often consider the individual caveats of therapy. For example, some of the guidelines say that if you failed surgery, then use this drug, and they don't think about whether that drug's really good for the patient or whether another drug might be better. They don't consider what the third-party payer mandates. So, for example, if you have a guideline that says use a somatostatin receptor ligand, and the physician tries to write for a different drug, the drug company can say, no, you have to use this drug because that's what the guidelines say. And that other drug may not work, and it may cost the patient money out of pocket for a drug that's not going to work just because the guidelines say so. And that's what I mean by the third-party payer mandates and ramifications. They don't consider the medical legal ramifications. If a physician decides that drug A is better than drug B, or treatment A is better than treatment B, and the guidelines call for treatment B, then is the physician liable if he does treatment B, but that was the wrong thing to do? So this is a big problem I have with guidelines, is that they're trying to tell people how to practice medicine, taking the art of decision making out of it. I do think they are too evidence-based, as I was alluding to just now, and don't allow a thinking person to make a decision with the patient to decide what's best for the patient. And who wants a cookbook telling you how to cook? You want to sort of apply your art to cooking. Cookbook is sort of the roadmap. It shouldn't really tell you exactly how to get to where you're trying to go. And guidelines try to tell you how to get to where you're trying to go. Another thing that complicates the guidelines and things like that is that the assays for IGF-I and growth hormone vary, and some of the guidelines are very specific about what they think your treatment goals should be. Furthermore, the drugs that are touted for management of acromegaly and the order that they're suggested, the drugs aren't as efficacious as they're supposed to be. Someone with acromegaly at 20 years wants to be on the best drug to control their disease. They're tired of the disease. They want to get levels down to normal. The guidelines are very time-consuming and arduous. They're hard. If you tried to follow guidelines to manage acromegaly, you'd be looking them up every day, trying to figure out what did it say about this or that. And they're really not as, even though they're thorough and multi-pointed, they're not as thorough as they probably could be or should be. The human brain does a better job of what some people can put on paper, and considering all the different caveats and different things that need to go into the decision making about treatment. And the last thing I'll say on this slide is that there never really is a consensus. And I've heard about some of these meetings, how people vehemently disagreed with the decision making about getting the guidelines together. And no two physicians really truly think alike, and I'm not sure that they should. That's the beauty of having a second opinion, of getting another physician to take a look and provide another potential alternative way of managing a patient's condition. Some of the problems that the guidelines have is that they fail to consider certain patient characteristics and omit them from the guidelines entirely. For example, age. I might treat a 25-year-old with acromegaly different than I would treat a 70-year-old with drug selection, goals of therapy, for example. The overall health of the patient matters. If a patient has minimal symptoms and signs and problems, that's one thing. If they have complications of the disease you have to take into consideration, you have to treat those complications as well. And the guidelines don't really focus on how you might adjust drug therapy based on other health problems like diabetes, for example. They fail to omit the fact that physicians and patients have different levels of education and understanding. And sort of related to this as well would be, that I didn't include here, would be the fact that not all centers are equipped with surgeons and radiation oncologists and even office staff in the physician's office to be able to provide the care for acromegaly that might be called upon by the guidelines. They also fail to consider the fact that patients have to be willing to accept side effects of medications. And, I have patients who often will choose one drug over the other based on the side effect profile. So you can't simply say you have to use this drug because the guidelines say so and then force a patient to accept side effects. The patient has to be willing to and permitted to play a role in the decision making. And when we say that we want to use drug A and the guidelines say drug B and the insurance company says drug B, the patient shouldn't be forced to use drug B because of guidelines which the insurance company is using. If the physician and the patient decide that drug A is better because of the side effects, for example, we should be able to go with drug A. So the guidelines don't consider this and they become too restrictive. Another thing is that guidelines don't consider tumor size and character, whether it's a small tumor versus a large tumor. And I will approach a small residual versus a large residual very differently when it comes to medical therapy, whether it's invasive versus non-invasive, or whether it's also secreting prolactin or other hormones, for example, like TSH. They also fail to look at the prior interventions and responses and the tumor characteristics, and I alluded to before the expertise of treating physicians. I alluded to the fact that comorbidities matter. If you have diabetes, for example, we may choose to use pegvisomant, which lowers glucose and insulin resistance, versus a somatostatin receptor ligand that can worsen diabetes mellitus. If you have a cardiomyopathy, and I've seen several patients who have acromegalic cardiomyopathy, you certainly want to avoid the dopamine agonist drugs, which are known to, in very high doses in Parkinson's patients, cause cardiac valvular disease. And I certainly wouldn't risk that in someone who, even though I don't think it's a problem at the doses we use, I wouldn't risk it in someone who has a pre-existing heart problem. The guidelines also fail to admit that radiotherapy is beneficial to many patients, and there was some physician bias that led to sort of the recommendation early on that we probably shouldn't be using radiotherapy for people with acromegaly, that we probably should be using medical therapy instead of radiotherapy. And that sort of found its way into the guidelines and got propagated and got taught to physicians. So now a lot of physicians don't consider radiotherapy as an effective tool in the management of acromegaly, but it is if you use it appropriately in patients of the right age group with the right tumor characteristics. And the benefit is you can get people off of medication with little potential for side effects. And then the financial constraints. The algorithms omit that the insurance coverage and copays also play a role in management of patients. An example, so I had a patient who took or had acromegaly probably for 25 years, had surgery, was not rendered disease-free due to invasive disease, and required medical therapy. And I prescribed pegvisomant because I thought it was the best thing to get the IGF-I level to normal. The insurance company said, no, patient has to try a different drug. We treated with a somatostatin receptor ligand. The patient really didn't respond. We wasted 6 months of trial on therapy. The patient spent money on the copay for a drug that didn't work because the insurance company said we had to use that because that's what the guidelines showed. Ultimately, we discontinued therapy after wasting 6 months and several $1,000s and put the patient on pegvisomant, and the patient has a normal IGF-I now and has had for years. So this is a financial constraint. This is an issue that the guidelines lead to problems like this that physicians and patients have to face. And it's another one of the different things that I think the guidelines don't consider that leads me to believe they're not necessarily the wisest way to be practicing medicine in this era. Now, I have several slides that use in a different program that go through some of the different bodies or entities and their particular guidelines, and they're all different. But I use this as an example of how arduous they can be and how biased they can be, and some of the problems inherent in having a group of experts, so-called experts, to write some guidelines and tell everybody how to manage the disease state. So one of the things that AACE did, and they published some guidelines in 2011, and they did a rating scheme for strength of evidence, basically where they looked at a lot of different papers and said this paper is a strong one or this is a weak one, and they tried to change the strength of their recommendations based on the publications. And then they had an executive summary of their recommendations they put together. It turned out that 4 of the 6 people who put the guidelines together were getting support from pharmaceutical companies. So clearly there's bias. You know, if a drug is made by a company and that company is paying you, you're going to be more likely to recommend that drug in a set of guidelines. And we don't like to have this sort of bias in the practice of medicine. And certainly my institution, that would be considered to be nearly sinful. So I couldn't believe that these people couldn't recuse themselves from participating in guidelines. The interesting thing is they drew their guidelines up and they submitted those to reviewers who were supposed to make sure that these were appropriate and not sort of biased. Well, 2 of those 3 reviewers get support from pharmaceutical companies, and one of them now works for a pharmaceutical company that made an acromegaly drug. So are you going to believe this? You know, I'm not. There's just too much bias there. They came up with a total of 119 different recommendations for the management of acromegaly. Some of them were as simple as the blood pressure should be checked at every visit. The patient should have an examination. I'm thinking, like, who are they writing this for? Medical students or endocrinologists or physicians that manage acromegaly? But it seemed overzealous and abundant, and I was concerned about the bias with these recommendations. Interestingly, this was the Acromegaly consensus group, and this just goes to show you how ridiculous this is. So the Acromegaly consensus group wanted to do a study to determine whether the consensus statements change clinical practice. So what would you do if you wanted to answer that question? You would probably talk to endocrinologists in the community and see whether or not they read the guidelines and whether the guidelines were useful. Well, what they did was they surveyed the 65 of the acromegaly experts who participated in the consensus workshop. And guess what? If you ask the people who developed the guideline whether they thought the guideline changed clinical practice, you're going to get this answer. 98% of respondents said that the primary treatment of somatostatin analogs was useful. 96% said pegvisomant monotherapy should be restricted to those who failed to achieve biochemical control. Of course, these were the people who were biased. And they concluded that most centers followed the consensus statement recommendations and that this encouraged the future utility of workshops. This is like asking the choir after a church service if they thought they sang well. Of course, they're going to say they sang well. And they're going to say that they should be invited to sing again. It's preposterous. It's garbage research. And, you know, it's like asking the mechanic if he did a good job fixing your car. Instead of them asking you if the mechanic did a good job fixing your car, they're asking the mechanic whether he fixed your car properly or not. So this is the kind of nonsense we get into when we have guidelines and the denoted experts are asked if they think they did a good job. And to me, it just illustrates how preposterous all this can be, especially when you put it in the context of some of the other things that I had said about guideline use in acromegaly. This is some of the things that came out of the consensus group in 2009. You know, it sort of brings up a number of different issues that they state that long-term studies indicate, this is how ridiculous these are, really. Long-term studies indicate that approximately 70% of patients receiving somatostatin receptor ligands have growth hormone levels below 2.5. Well, now we look for better levels and a normalized IGF-I. So in unselected populations, which means real life situations, growth hormone levels less than 2.5 and normalization of IGF-I in 44% and 34% of patients respectively. So they're saying here, studies say 70% of people respond, but then other studies show that only 44 and 34% of people achieve the two goals, 34% getting a normal IGF-I. And it's probably, with some drugs, even lower. So their guidelines, based on that evidence, say that the use of somatostatin receptor ligands is most appropriate potential first-line therapy. You know, so they're saying a drug that we now think maybe works 25 to 28% effective or 34% effective in most cases, maybe up to 40%, should be first-line treatment. And this is even after David Clemens wrote his recommendations in around 2003, 2005, thinking that, you know, you could use any drug as first-line therapy in acromegaly. You don't need to use a somatostatin receptor ligand first if you think pegvisomant or cabergoline are better choices for the patient. And yet 5 years or 7 years or 8 years or so after his paper, people are now saying you should use somatostatin receptor ligands even though they only work in maybe a third of people. And again, these people are paid experts who go to this consensus, who receive research support or other monies from different drug companies. So to me, it's all sort of wishy-washy. You wonder about the strength of recommendations if they're recommending that everybody try this drug first, even though it works in 1/3, when there are drugs that work in a greater proportion of people that might be a better choice. So again, this is the problem with the guidelines as I see it. Just a couple things now to get a little bit away from the guidelines and talk more about some of the approaches that I take that I think you can usually take to the bank and talk to your physicians about it. Not to say that I'm right, but it's sort of, after 30 years now of doing pituitary endocrinology, it speaks a little bit about how I have evolved my thought process of treating acromegaly over time. So when I started out with my first patient with acromegaly was 1988. All we could do for people at the time was surgery and then radiotherapy, and it was conventional radiotherapy. We didn't even have gamma knife radiosurgery in the United States at that time, at least not to use clinically. And bromocriptine was available, and it would control about 10% of people with acromegaly. All these other drugs, the fancier and more effective somatostatin receptor ligands, pegvisomant, cabergoline, gamma knife radiosurgery, all that has come out during my practice, and I've been able to see the evolution of treatment so that now we can control about everybody. The other thing we've understood and known is that some of the early studies that looked at the success of acromegaly were based on assays that weren't as good, and we didn't have survival data. But now that we have better assays and survival data, we've changed the goals of therapy. They've evolved over the past 3 decades. There's still some disagreements about what defines a cure or remission. Some people think you're never cured, you're just in remission. I disagree with that a bit. But we have set the bar higher, and now neurosurgeons must pole vault instead of doing a high jump. That bar has become so high. I remember early in my training, they used to think of a growth hormone level less than 5 as a successful neurosurgical procedure, whether there were residual tumor or active features of acromegaly or whatever, or whether the IGF-I was even normal. A growth hormone level less than 5 was a successful operation. Then we started going for less than 2 and 2.5 in some of those studies, and now we want a level less than 1, and we want that IGF-I level to be normal. And there's some data that suggests it should be in the lower half of the normal range instead of in the higher half of the normal range. But we still haven't figured out what to do with those patients who are normal if they don't have residual tumor on an MRI. So my watch out thing here is that many of the look how good we are papers, which a lot of institutions write, even my own, they employ the older criteria and speak of high success rates. So if you come across a paper from the 1990s that says, you know, at our institution, we cure this proportion of people with acromegaly, that's old data, and you have to be suspicious of that. And you know, really you want to look at the modern data and criteria and hear how people are doing before you think about surgery based on a paper that you read somewhere that comes from several decades ago. I think in this day and age, most pituitary endocrinologists demand of the neurosurgeons or to be able to say a patient's rendered disease-free, a normal age and sex-adjusted IGF-I and a random sensitive growth hormone level less than 1.0. If a patient doesn't meet those 2 criteria, then we usually proceed with an oral glucose suppression test using a sensitive growth hormone assay, and we want to see a growth hormone level less than 0.4 nanogram per milliliter. Now the guidelines have sort of evolved to this, but I share this because this is more the way I think in the traditional thinking that people have. But some of the recent guidelines don't have this stringent criteria, but I think this is really what we're hoping for when we see patients go to surgery this day and age. I still believe surgery is the first-line treatment in most situations. You could argue that if you have a tumor that's slightly invasive and is not going to be cured with surgery, and you have to have surgery, but then you have to be on medical therapy or radiotherapy, you could argue that maybe just treat the patient with medical therapy and avoid surgery. because you're going to have to be on medical therapy anyway. But if you hope to treat with radiotherapy and get the patient off of treatment, I think it's reasonable to go ahead and debulk the tumor. The other thing is that patients tend to respond better to medical therapy the smaller the tumor residual. So that, you know, I've spoken to physicians from other countries, for example, who would treat a patient with a dopamine agonist drug instead of send them to surgery. And if they respond, then great, you stay on oral therapy. If they don't respond, they might try to debulk the tumor, then try the dopamine agonist drug, or go to a somatostatin receptor ligand or whatever to try to control the disease process. But in an era where we still have health insurance coverage and we can sort of pretty much get people to surgery as first-line treatment, even if we won't render them disease-free, I still think it's best to debulk a tumor up front. But I wouldn't have a problem if a patient had mild invasive disease with no mass effects and normal pituitary functions. I wouldn't have a problem trying medical therapy with a dopamine agonist drug only prior to going to surgery. But generally, I recommend surgery for most everybody because it makes medical therapy easier to manage. I think it's critical to choose an experienced surgeon and neuroendocrinologist. And, you know, I tell people that, you know, you should find the best surgeon possible for your disease process and go see a pituitary surgeon who's done a couple thousand operations. It's definitely worth the airfare and the hotel stay, if your insurance will cover it, or if you've got the money to pay for it, to go to the very best surgeon that you can find. We see so many people at our institution here at UCSF who have had surgery elsewhere, and they come here and we can cure them with the second operation. We just wish we could have done it on the first operation. Even people who've been referred for radiotherapy, who come here for a second opinion, we take them to surgery and cure them. And there are other physicians who practice neurosurgery for pituitary disease who can do the same thing. So, you know, go see an experienced surgeon. If you didn't get an experienced surgeon up front, consider a visit with an experienced team prior to additional treatment, especially radiotherapy or additional surgery by a surgeon who failed, if they're not one of the top tier pituitary surgeons. Because I think repeat surgery may be a better option than radiation or medical therapy for many patients. And it's best to go ahead and get that opinion. You know, that's less expensive than a lifetime of a drug therapy or radiotherapy with the consequences of radiation treatment. In general, if you go see experienced surgeons, you can get control of your IGF-I and be in remission 75 to 95% of the time, depending on the surgeon. If you have a microadenoma, control rates and cure rates are lower in patients with macroadenomas, whether they invade or not, and especially if there's invasive disease. But still, in people with local invasive disease, you can get a significant control rate with surgery, and it's worth going to find those good surgeons to get that control. Radiotherapy, some of the guidelines, as I mentioned before, say never use it, just use medical therapy. Some are starting to come back and suggest that it does play a role. It should almost never be first-line treatment because of the risk of pituitary apoplexy and blindness or double vision when that can happen, as well as pituitary failure. But I've seen it used in first-line therapy in people who are too sick to go to surgery. I would treat with medical therapy in that setting and not give radiotherapy because of the risks of pituitary apoplexy. But I think of it as a very good adjunct to surgery or an additional treatment following surgery. Some say don't treat anybody, others will say treat everybody. I had to sort of figure out how I'm going to use radiotherapy in my practice. And the way that I do it is if you're over 45 years of age, I think radiotherapy is reasonable to do up front, especially gamma knife radiosurgery after you've failed surgery, for example. I'll use it if you're younger, if your tumor is progressing, growing, or if you fail medical management. But generally speaking, I reserve radiotherapy for the older person unless you're younger and you're getting in trouble from your disease. One of the reasons being is that the time course to develop hypopituitarism is after radiotherapy, even gamma knife, is somewhere between 3 to 10 years. But I've seen a lot of people have conventional old-fashioned radiotherapy and have a lot of really amazing, devastating side effects of the high doses of radiation that used to be given. I haven't seen those dramatic, devastating side effects in gamma knife radiosurgery. And I do believe the hypopituitarism after gamma knife radiosurgery is much less than it is after conventional. So I think there is a role for radiotherapy because you can control the tumor and discontinue medicine in probably 70–75% of patients over time. And if you're 45 years of age, why would you take somatostatin analogs or pegvisomant for the next 30–35 years when you may be able to get gamma knife radiotherapy and come off medications within 7 to 15 years of treatment? So I think it's less expensive overall to do the radiotherapy. It's probably more efficacious and better, and you get better, you don't have to worry about complying with injections, etc., to go ahead with the radiotherapy and then one day come off the medical therapy. And the risk of hypopituitarism with gamma knife is probably 40%, and it's easy to treat. So you develop growth hormone deficiency or a central adrenal insufficiency or central hypothyroidism or gonadal dysfunction. Those therapies are easier to treat than acromegaly. And it's an example, as with most any disease process, there's a trade-off, right? You've got an intervention which has complications or a drug that has side effects. You're trying to treat something that can kill you for something, and you trade it for something that you can manage fairly straightforwardly, taking medication daily. So unfortunately, in some diseases, you have to do that trade-off. Nothing's for free, so to speak. But this is sort of my approach to radiotherapy. The guidelines, like I said, often omit that. And one of the concerns I have is that the guidelines say don't do radiotherapy or use it in extreme cases. Then they could potentially deny it for people who say, I would really like to get radiotherapy to come off the medication in a few years and not have to worry about taking injections for the rest of my life. The patient should be able to make that choice. It should be an individual decision between the patient and the caregiver, and not the insurance company or a bunch of experts that sat around and later wrote articles saying how great they did. All right, so medical management of acromegaly, I think, is usually best reserved for those who fail to achieve control with surgery or radiotherapy. You can use it before surgery in patients with severe respiratory or cardiac compromise. So I have people with severe sleep apnea and pulmonary dysfunction or severe heart failure, and I will treat them with drugs before surgery. I usually would use the somatostatin analogs because you can sometimes decrease tumor size and maybe increase the likelihood of remission. There have been a number of studies done over the years looking at whether somatostatin analogs before surgery improve surgical outcomes, and you have an equal number saying they do and an equal number saying they don't. It probably depends more on the skill of the surgeon. So I don't use them to try to improve cure rates, but I will use them to improve a patient's overall situation so they have a safer operation. And I can see improvement in sleep apnea, respiratory function, and cardiac function by treating those patients prior to surgery with somatostatin analogs. And I alluded to this before. One might argue from an economic perspective that some patients with invasive tumors should be tried on dopamine agonists before surgery. If you live in a country that has a national health service plan, they may say that why should we spend, $80,000 to $100,000 on surgery when we can just treat you with a drug that you're going to need after surgery anyways. Makes perfect sense to me. I don't know what I would do if I were the patient. I guess it would depend on the size and invasiveness of my tumor, but I let patients make that decision. I think that it's imperative, if you're considering medical management, either before surgery or after surgery, or before or during or after radiotherapy, that you see a pituitary endocrinologist who knows how to use these drugs and knows the caveats of their use. Caveats meaning sort of the little, oh, if this, then that type things, and things that modify decision making, or an endocrinologist who can be able to educate your local physician to manage this over time. I know that not everybody lives close to a tertiary center, but it's always worth a consult and then to take the plan back to your endocrinologist and let the two doctors sort of set up a relationship to manage your situation. There are a number of drugs that we use to manage patients with acromegaly. As I said before, all we had was the one at the top, bromocriptine. Now we have cabergoline, which is a more potent dopamine agonist drug with a longer half-life, so it can be used less frequently than we had to use bromocriptine. And then we have the somatostatin analogs. There's a native somatostatin, or the first somatostatin that came out that required every 6 to 8 hour injections. Sandostatin LAR, which is once a month, somatostatin depot, sigma-4 depot, and then we have the growth hormone receptor antagonist, of which now there's only one drug in the class, that's pegvisomant or somivert. The dopamine agonist drugs bind to the dopamine receptor, which is a protein on tumor cells that is connected to sort of different processes within the cells, and it's actually a receptor that's present in the stem cell that ultimately becomes either a prolactin cell or a growth hormone cell. And because of the common lineage or the ancestors of these prolactin and growth hormone cells, sometimes we get tumors that produce both prolactin and growth hormone. I saw 2 patients yesterday with different types of tumors. One had a tumor that had cells that also produced prolactin and cells that produce growth hormone, and the other one had tumor cells that were more of a primitive combined cell called a mammosomatotroph cell, where the same cell produces prolactin and growth hormone. The bottom line is some of these tumors still have these dopamine receptors. So if we use a drug that acts like dopamine, that's what an agonist is, like Acromegaly, it can act like dopamine and inhibit growth hormone and prolactin release from those cells. So the possible candidates for treatment are patients who have tumors that also secrete prolactin. I have found that people with only mild elevations in IGF-I, like I saw one yesterday, one of my 2 patients I just mentioned, who went to surgery, had invasive disease, but his IGF-I level now is just minimally elevated. Those patients you can often normalize their IGF-I with just a little bit of medical therapy with the dopamine agonist drug. And if for some reason elderly patients tend to respond very well to these drugs, relatively better than younger people. However, I do have a gentleman in his 40s who we've got great control with Acromegaly of his residual acromegaly, and he's doing fine on treatment. So I don't want to say you can just restrict it to elderly, but in my 30 years of practice, that's sort of where you start to see people who are more likely to respond. Acromegaly is the preferred of the 2 drugs, and that's largely because bromocriptine should probably be taken in very high doses, at least 2 to 3 times a day. With Acromegaly, you can usually treat once or twice a week. I have a couple people taking it 3 times a week or every other day. High doses of the dopamine agonist drugs may be required in people with acromegaly, and I've been known to use 3.5 milligrams a week, for example, in one case 7 milligrams a week. And you'll see normalization of IGF-I in 10 to 40% of people if you look at the different studies that have been conducted. And again, the ones who most likely are going to respond are those who have elevation of prolactin or co-secretion of prolactin from their pituitary adenoma. This is a classic example of why you have to have surgery at a place that's got a good pathologist as well, because if they don't have a good pathologist and they're not doing immunostains for pituitary adenomas to find out what kind of tumor you have, forget it, because that initial information is useful to the endocrinologist who's trying to figure out the best pre-treatment approach. So go to a tertiary center where they have good pathology, do immunochemistry. And I see so many times people at surgery at a small hospital in California, we don't have any data. We just know that they confirmed a pituitary adenoma. They didn't do any special tests to tell us anything about that tumor. So this is a classic example of where immunochemistry in a pathology department helps me in the clinic with my patients deciding what to do next. The somatostatin analogs are drugs that act like somatostatin. There are somatostatin receptors on pituitary cells that produce growth hormone and some TSH cells as well. But the somatostatin receptors, when they're activated, inhibit growth hormone secretion. So you have growth hormone releasing hormone from the hypothalamus that stimulates growth hormone secretion by growth hormone cells. And then you have somatostatin, which inhibits that secretion of growth hormone by the cells. And somatostatin, being a negative factor here, is the most important hormone controlling growth hormone secretion from normal cells. Since tumors come from normal cells, many of these tumors have somatostatin receptors on them. However, not all cells do. Since they're less differentiated or less mature cells, they often lose receptors. The receptors aren't tied to the inner workings of the cell properly. But in many patients, they are, and you can activate that receptor or bind to that receptor with a somatostatin analog, a drug acting like somatostatin, and inhibit growth hormone production and release, and maybe control the cell cycle and cell division in some of these patients with growth hormone secreting pituitary adenomas. With regards to the somatostatin analogs that I showed you earlier, there are marked differences in the products. Some of them have better injection situations than others. The half-life's different. The way the drug gets absorbed into your system after you inject it is different. The side effect profiles are all similar, largely being gastrointestinal in nature. And the efficacy varies greatly from drug to drug, and even in the same different studies of the same drug. I think the best one can really hope for is about 40% control of patients, and it is possible to see tumor shrinkage in some people. The growth hormone receptor antagonist, bagpipes or Somivert, actually binds to and incapacitates or makes non-functional the growth hormone receptor on cells, so it can lower IGF-I and block the effects of growth hormone directly on cells. It's probably the best efficacy of all drugs. The research studies showed 90% of patients achieve control of IGF-I if you push the dose. Couple problems. One, physicians in practice don't push the dose. They'll treat you with a low dose or a medium dose and say this is the best we can do, and they're afraid to use the maximum dose of the drug. There was a study that came out after this drug was released showing that you get 67% control or thereabouts. I think the problem is when you look at the average doses of that level of control, people weren't pushing the dose of the drug. This is another reason to go see an expert endocrinologist, is because, believe me, endocrinologists who do mostly diabetes and have the rare acromegalic patient walking into their office don't really know how to push these drugs and how to use them, and especially how to use them in combination. There are a couple of problems with the growth hormone receptor antagonist. One, you can get liver function test abnormalities in about 2% of people. They go away if you stop the drug. You can get local skin reactions with either lipoatrophy, where the fat layer of the skin shrinks, or some allergic reactions where I think patients actually have a latex allergy because the cap that the needle goes through to draw the drug up is actually made of latex. You can use combination treatment, and there have been several studies looking at the different drug combinations. My favorite one is a somatostatin analog and pegvisomant. So if a patient's on the somatostatin analog first and they get a partial response, I'll add pegvisomant usually twice a week and then decide whether I need to use it every day or what dose I need to use based on the response. However, and I've seen so many times patients have been treated with somatostatin analog, had zero response, and physicians then added pegvisomant. There's no reason to continue the first drug if there's zero response. You've already shown that that patient doesn't have receptors on their tumor cell membranes, and they shouldn't really be treated. So as patients out there, if you are seeing your doctor and you had no response in your IGF-I and they're thinking of adding a pegvisomant or bromocriptine or cobergoline, you should just stop the somatostatin analog. It's not going to do anything if it didn't work. So there's no point in continuing the drug that's not working. But if a patient starts on that drug and gets a partial response, I'll add pegvisomant. If they start on pegvisomant and don't quite have a complete response, I may add a somatostatin analog. So my basic rules there are just things that, work with your physicians. Ensure that the treatment of the first drug has been optimized. So you don't want to start a second drug if you haven't been on the maximum dose of the first drug if it worked partially. You want to go to the maximum dose of the first drug. If it doesn't work at all, don't use it. Switch to another drug. So if there's a partial response to the first and combination therapy is considered, then think about switching to a second drug rather than adding a second. Just maybe go to the drug B instead of adding drug A and B, and use the low doses of the second drug and then titrate one or the other as necessary. So you have to work with the physicians to decide a plan, and hopefully you can refer to this later or look at this later. But these are some of the basic rules or guidelines that I would recommend to people that sort of are common sense that I've learned to develop after dealing with so many patients that you don't see in the guidelines. You don't see these basic rules, and you don't see physicians employing these because they don't have the experience with acromegaly, but it's sort of how I practice medicine there. This is a profile of a patient I took care of in the year 2000 to 2004. So this was when I was on faculty at Vanderbilt and directing the Pituitary Center there. And it's basically IGF-I data and treatment history of a particular patient who came in with acromegaly. And you can see on the bottom there that around March of 2000, she had transfemoral surgery. IGF-I was up. She didn't get cured, had residual tumor on her MRI. So she had additional surgery and received computerized photon knife radiotherapy. And then you can see the orange arrow showed when she started sandostatin LAR therapy, and that normalized her IGF-I. And you can see there in September 2002, roughly 2 years later, her IGF-1 was normal. She was miserable in response to the drug, terrible GI complications of the disease process. And she said to me, how do you know the drug hasn't, or the radiotherapy hasn't worked and I can just come off this drug? And I says, well, I'm not yet seeing what would indicate to me that that's the case. So she wanted to stop the drug to see what happened. So she stopped it, and you can see that her IGF-1 level rose back into the red parts there up to 600 or so, almost as high as the original. And we treated her with Somavert for literally about 9, maybe 10 months, starting with low doses, maximizing therapy, getting her on the most dose necessary. Nothing worked. She didn't respond to that drug. She didn't want to go back on the Sandostatin LAR because she was miserable. So I started her on Cabergoline, and you can see that that brought her IGF-1 level down to normal around April 2014, and it was normal. You see the 378. The reason that was high, she said she stopped the drug because she wanted to know if she'd responded to radiotherapy yet. So she went back on the Cabergoline. And then I didn't have a slide with the rest of the data, but for the next 3 years until I sort of moved out to California, her IGF-1 was normal on Cabergoline. And every time she would stop it, the IGF-1 would go back up to a high level. It illustrates that I like this slide because it illustrates the choices that we have to make as patients and physicians together to figure out what drug works, what drug doesn't, what side effects are worth tolerating. And the surprise here is the drug that we tried last probably was a drug that maybe we should have tried first. It controlled her disease process. And, it took several years of misery for her to sort of want to stop the drug. And the LAR, the Somavert didn't work. Maybe we should have tried Cabergoline at the outset, and we would have had her under control. All right, well, that's about all I have to say. This is one of my paintings of Point Reyes. If you know, Point Reyes is a landmass that's out here in Northern California, north of the city, and it's actually on the Pacific continental plate, it's on the other side of the San Andreas Fault. It's not on the American continental plate. It's a lovely place to go if you're ever in the Bay Area, and this is just some of the sea cliffs in that region. I have patients in about 8 minutes, so I have a little bit of time for some questions if you'd like to ask those now.
Excellent, thank you. A few questions. I'm a 76-year-old pan-hypopituitary female. I was diagnosed in '88 and had 2 transsphenoidal surgeries and a 96 stereotactic proton beam radiation in Boston, plus Sandostatin injections 3 times daily for years. IGF-1 normalized for 6-ish years, then elevated. Was put on Cabergoline 0.5 milligrams twice a week and have been well controlled since 2011. My doctor decided to try dropping the Cabergoline, but it went up from 104 to 154, range up to approximately 164. So I went back to regular dose for 3 months and retested with results of 265, well out of range. My Cabergoline dose was doubled, and I'll retest the first week in August. I'd like to know what's next for me if I don't normalize.
That's a very interesting history and story, and almost similar to the last patient that I showed there. The fact that the drug is losing its effectiveness after so long makes me wonder whether there's progression of residual disease. And it would be worth an MRI to take a look to see whether or not tumor is progressing and something else needs to be done against that tumor.
Okay, thank you. Should acromegaly patients that have signs of underactive thyroid but have normal lab tests, should they be on a thyroid medicine, and should a patient with 1/4 of the thyroid be on medicine that has acromegaly?
Those are very good questions. My own personal approach is that if you have pituitary disease and you have symptoms and your levels are normal, to look and see where in the normal range those levels are. If they're in the lower part of the normal range, I treat those patients with thyroid hormone, and in almost all cases, those patients improve with treatment. So, for example, I think that my goal for thyroid hormone in patients who have pituitary disease is for their T4 and their T3 levels to be in the upper half of the normal range. So take the normal range, split it down the middle, and your level should be somewhere in the upper half of that. without symptoms of hyperthyroidism resulting. So if you're in the lower half of the normal range and you have a history of acromegaly, pituitary surgery, radiotherapy, or whatever, then yes, if you have symptoms, by all means, it should be worth considering treatment or discussing dose changes with your primary physician or endocrinologist to try to get those levels to the upper half of the normal range as a trial to see if you feel better and your symptoms resolve. And the patient with a quarter of a thyroid, that patient has less thyroid reserve or less pituitary thyroid reserve, and if they also have acromegaly and pituitary disease and are in the low part of the normal range, they probably do need to be on thyroid medication.
Okay, great, thank you. Does increasing the dose of cabergoline work better in acromegaly than with prolactinomas?
It's hard to say. I do think that in both disease processes, you push the drug as needed. Regardless of acromegaly or prolactinomas, you can push the drug in each to as much as you need to use. I had one patient come to me, she was taking 1.5 milligram of cabergoline a week total, and her physician said, that's the maximum dose, there's nothing more I can do. And I says, well, yeah, we can go up on the dose. So we end up on the dose, and she's now has a normal prolactin. So I think I'd have to say that people with acromegaly are a little bit more resistant to the drug and tend to require higher doses than those with prolactinomas do. But I tend to sort of back away from that and just use the drug as necessary, as tolerated, at whatever doses we require to try to normalize the hormone level and to control tumor progression.
Great, thank you. Should precaution be taken for women who are interested in pursuing IVF? 37-year-old GH-TSH secreting macroadenoma, acromegaly in remission, some residual tumor, however, no symptoms.
So, it's interesting, if there's residual tumor, it would lead me to believe that it's not that functional. If the thyroid hormone levels are normal and the IGF-I and growth hormone levels are at target, I think it'd be okay to try to proceed with the pregnancy. Just have to watch the thyroid hormone component of that very closely. Interestingly, during pregnancy, the estrogens made by the placenta tend to suppress IGF-I levels, so people with acromegaly who are pregnant will actually have improvement in their disease, and you don't need to use medical therapy to manage acromegaly during pregnancy. But I would be concerned about the thyroid, the TSH production, the thyroid hormone levels during pregnancy, and would simply recommend close monitoring in that setting. I wouldn't tell a patient that this disease process would preclude her getting pregnant, but would just recommend careful follow-up and attention to the thyroid levels, and maybe an anti-thyroid drug during pregnancy if they became abnormal.
Excellent, thank you. Do you have any recommendations for patients that need to fight their insurance companies because of the guidelines? Any tips that you can provide to help them kind of navigate through that?
Probably the one thing that works the best is to have a strong physician advocate. So be willing to work with a physician who will take on the challenge of calling the insurance company and talking to their reviewer to determine whether or not that patient is truly qualified to try a certain drug outside of the guidelines, and a physician who's willing to say that the guidelines are worthless and insurance companies shouldn't use it. That's the best thing, is to have a physician advocate. I think that patients are not going to win those battles usually. It's best to have a physician advocate who can have a communication with the physician on the other end who's making the decisions. And unfortunately, not all the time, but most of the time, physicians who are on the other end of the phone working for the insurance company don't have any understanding at all of the caveats of treatment of acromegaly. So I've talked to some of these physicians. I ask them, what do you do for a living? I'm a retired family practitioner, and I just do this to make extra income during my retirement. That's the worst situation ever for a patient with acromegaly, to know that a family practitioner who's probably never seen a case is the one making the decisions, following the guidelines, and supporting the insurance company's decisions. And I usually sort of get those approved ultimately through a conversation that I'll have. Sometimes you get a reviewer who's an expert in the field, and they're making decisions based on guidelines, and they're willing and able to sort of change and say, oh yeah, you make a good case for that, so I'll approve it. So it's worth having a physician make the phone call and trying to sort all of that out and get to the internal workings of what's going on leading to that decision.
Great advice. Thank you. Also another thing that shows how important specialists are in treatment for acromegaly and other pituitary disorders. I know you have patients to see. Dr. Blevins, thank you so much for taking the time today.
I think the first one is here, so I better run.
Okay.
I think y'all enjoyed at least talking. I hope you enjoyed it out there, and pay attention to some of these things, and be an advocate for your health care, and learn as much as you can.
Absolutely. We agree with all of that. This concludes today's webinar presentation. We appreciate you taking the time to join us. If you missed any part of this webinar or would like to share it with family and friends, it will be available on our website, www.pituitary.org, after it is edited. There will be a brief survey at the end. Please fill it out to help us provide you with the information you need. Thank you all for joining us, and everybody have a great day.